Welcome to this explainer. Let's jump right in. Today, we're demystifying the incredibly complex medical, legal, and ethical landscape surrounding some of the most vulnerable migrant populations in our society, refugees and asylum seekers. It's a fascinating and, honestly, quite challenging space where fundamental human rights crash right into strict bureaucratic rules.
Okay, let's dive into this. Have you ever wondered why a simple word, just a label assigned to someone, dictates the actual medical care they are legally allowed to receive? It's a stark reality. Whether someone is legally designated a refugee or an asylum seeker literally changes the rules of their healthcare. So let's unpack exactly how and why that happens. Here's our roadmap for today. We'll briefly cover Section 1, Labels in the Journey, then look at Section 2, NHS Rules and Entitlements, followed by Section 3, Complex Health Needs, and wrap up with Section 4, The Ethics of Care. Basically, we're moving from the human experience and legal definitions straight through to the clinical realities and overarching philosophical questions.
All right, Section 1, Labels and the Journey. To really understand the rules, we first have to understand exactly who those rules apply to.
Let's draw a clear, vital distinction between these foundational legal statuses. On the left, a refugee is a very specific legal term defined by the 1951 UN Convention. It refers to someone who is outside their home country and has a well-founded fear of persecution. On the right, an asylum seeker is someone who has applied for that official refugee recognition but is still waiting for a final decision. Oh, and there's a third important category we need to keep in mind, a refused asylum seeker. That's someone whose initial claim was rejected, but who might still be appealing or submitting fresh claims.
Now you might be wondering, why does this matter? Well, because these labels aren't just administrative paperwork filed away in an office somewhere. They act as literal gatekeepers to healthcare. These specific legal terms directly dictate NHS entitlement rules. And beyond the hospital doors, these labels also shape public narratives. They fuel intense political debates about moral legitimacy, really driving arguments over who is seen as inherently deserving or undeserving of state-funded care and support.
And this brilliantly illustrates how those bureaucratic labels link directly to a person's lived reality. The British Medical Association, or BMA, encourages clinicians to view a patient's journey in 3 distinct phases of vulnerability. Phase 1 happens before departure. Think conflict, persecution, and entirely disrupted healthcare systems. Phase 2 is during transit, which is characterized by highly unsafe travel, exploitation, violence, and a complete lack of necessary medication. And finally, Phase 3 is after arrival. Even in a supposedly safe host country, they face poverty, unstable housing, isolation, and immense legal stress. Grasping this timeline is absolutely crucial for providers to build empathy and context for their patients' clinical needs.
Moving right along to Section 2, NHS Rules and Entitlements.
Let's shift gears from the human journey to the bureaucratic reality, focusing on how the UK's National Health Service actually processes and treats these populations. But before we look at specific services, we need to highlight a critical professional boundary outlined directly in the government and medical source material. Clinicians are caregivers. They are not border policy enforcers. It is emphatically not a doctor's role to determine immigration eligibility. Their essential role is making clinical judgments regarding the urgency of care and supporting safe access for patients who desperately need it.
Let's start with the major source of support, primary care, like registering with a general practitioner. The rule here is incredibly straightforward. Primary care is free for all across the entire UK. Refugees, asylum seekers, and even refused asylum seekers have a universal right to register with the GP. And this is huge. GP practices do not need identity documents or proof of address to register patients. Turning someone away because they lack this specific paperwork under NHS guidelines, that is simply unacceptable as a default approach.
Now, what's really interesting about this slide is the sharp geographic divide when it comes to secondary care. Think hospital treatments, surgeries, or specialist referrals. For active asylum seekers and recognized refugees, it's free across the board. But for refused asylum seekers, while care is generally free in Scotland, Wales, and Northern Ireland, they might actually be charged for some secondary care in England unless a specific exemption applies. It's a real patchwork system.
But despite those charging rules in England, there are absolute protections built into the system to serve as an unconditional source of support and prevent catastrophic outcomes. Urgent or immediately necessary life-saving care is never withheld or delayed for charging issues, regardless of a patient's legal status. Maternity services are always classed as immediately necessary, and e-services remain completely free. Plus, treatment for communicable diseases is exempt from charges to protect broader public health, and care for any conditions caused by torture or sexual violence is universally protected.
Okay, Section 3, Complex Health Needs.
We've seen the legal frameworks, so let's transition to the clinical impact. The AMI outlines the common health challenges of these populations by placing one critical factor right at the center of this visual map: language translation needs. Whether a clinician is trying to figure out the right dialect, understanding gender preferences for interpreters, or navigating complex cultural nuances, effective communication is the core hub required to actually deliver care across all the surrounding medical needs.
Radiating out from that communication hub are 4 specific clusters of complex health needs. First, poorly controlled chronic conditions like hypertension or diabetes, which are often severely exacerbated by months without medication. Second, massive mental health needs. We're talking PTSD, severe isolation, and trauma from torture or gender-based violence. Third, maternity care, which is frequently complicated by late presentation and malnutrition. And fourth, untreated communicable diseases like TB or just missing routine vaccines. As you can see, these clusters directly trace back to that 3-phase timeline of trauma and deprivation we established earlier.
When discussing these complex needs, the BMA toolkit explicitly challenges a major political assumption. They impartially note that there is absolutely no evidence that refugees and asylum seekers disproportionately burden the NHS. They actively warn that portraying migrants as systematic health tourists can dangerously distort public attitudes and create informal barriers to care for people who are already intensely vulnerable.
Let's move to our final segment, Section 4, the ethics of healthcare. Let's see how this all builds into the bigger picture.
We are now pivoting from clinical guidelines and hospital charging rules to the profound philosophical and moral questions that sit at the very heart of migrant healthcare. The source literature identifies 5 specific clusters of ethical dilemmas that healthcare providers and societies as a whole must actively grapple with. 1. Justice and fair access. What are people actually owed in fairness when resources are unequal? 2. Human rights and moral universality. 3. Deservingness and boundary drawing. How do we decide who belongs inside our circle of care? 4. Solidarity versus self-interest. And 5. Language barriers and epistemic injustice, ensuring marginalized patients are actually heard and structurally understood.
Bioethicists argue that medical duties should be grounded in human vulnerability, not passport stamps. Researchers Nora Gottlieb and Yitzhak Ben Mocha summarize this powerfully. They state, if health is a basic human interest, then excluding people from care because they are outsiders is morally difficult to defend, especially where it worsens suffering. They are arguing for moral universality, basically asserting that a doctor's duty is fundamentally tied to a patient's sheer human need.
So what does this all mean? It brings us to the ultimate intersection of human rights, legal boundaries, and medical ethics. I want to leave you with a provocative question posed by bioethicist C. Klingler. Should access to essential healthcare depend on citizenship or immigration status? It's a profound question that really challenges what we value most as a society. Thank you so much for joining me today. I hope this structured journey has helped clarify the very real complexities of refugee and asylum seeker healthcare and leaves you with plenty to think about. Keep learning, and I'll see you next time.